Hello viewers, today we are going to talk about the approach to a patient with stridor. Stridor is noise produced during breathing when turbulent air passes through narrowed air passages, and often it can be a sign of a very serious respiratory problem. As a medical professional, it is important to know how to approach this situation with confidence and utmost professionalism. First, we need to assess the airway and breathing of the patient because stridor is almost always a respiratory emergency. We need to assess whether the patient is able to speak in full sentences, whether the patient's voice is hoarse or not, whether the patient's skin color is normal or not, is there bluish discoloration or cyanosis. All these factors are important in evaluating a patient with stridor. Next, we need to determine the cause of the stridor. Stridor itself is not a disease, it is a sign of respiratory emergency in most cases. Is stridor due to an obstruction in the upper airway? Is stridor due to an allergic reaction like anaphylaxis? Is stridor due to an infective condition like epiglottitis? A thorough physical exam and history can help us narrow down the possibilities. Once we have determined the cause, we need to begin treatment. Treatment may include administering oxygen, starting medications such as epinephrine and or steroids, or going for emergency airway management such as intubation or tracheostomy. Now let's dive deeper into the topic and understand what are the different types of stridor, what are the different causes of stridor, and how to evaluate and treat a patient presenting probably to the emergency with stridor. But one thing we should remember at all times is, as medical professionals, we need to be aware that stridor may well be a life-threatening condition, and while evaluating and treating a patient with stridor, we have to be acutely aware of the fact that more often than not, it may well be a race against time. Let's get into it. Stridor can be of three types: inspiratory stridor, expiratory stridor, and biphasic stridor. Biphasic stridor refers to stridor that is present both during inspiration and during expiration. Typically, biphasic stridor is seen when the pathology lies either in the glottis or in the subglottis or in the cervical trachea or in all of these areas. Now, if the pathology lies somewhere above the glottis or superior to the glottis, the stridor is likely to be inspiratory in nature. If the pathology lies somewhere below or inferior to the cervical trachea, the stridor is likely to be expiratory in nature. Now, we are all aware of the fact that the respiratory tract starts in the nose and the oral cavity and ends in the lungs. So, if we can identify the type of the stridor, we can estimate the likely site of the pathology in the respiratory tract. We have to remember that stridor is an acute emergency, and some history questions can also help us understand what is the exact cause of the stridor. However, while eliciting history, we have to remember that it is a race against time, so we have to be focused and elicit history in a prompt and timely manner. So let's discuss the history questions that we should ask to understand the cause of the stridor. It is important to find out the following information when we are treating a patient with stridor. Number one, we have to find out the time of onset. Is the stridor present since birth or not? We have to find out the mode of onset. Is it gradual in onset or sudden in onset? We have to find out the duration of stridor. Is it of short duration? Is it of long duration? Is it gradually progressive or not? We have to find out if the stridor is associated with episodes of feeding or not. If stridor is present during feeding, it may indicate vocal cord paralysis or a laryngeal cleft. Each question can indicate a possible cause, or it can also help us in ruling out some common causes. We have to ask if the patient has any history of inhalation of a foreign body. Is there any history of ingestion of a foreign body? Is there any history of cyanotic spells? Because cyanotic spells can indicate airway compromise. Is there any history of laryngeal trauma or trauma to the neck? Because blunt trauma to the neck can produce stridor, intubation trauma can produce stridor, and even endoscopy can produce trauma that may lead to stridor. So all these questions need to be asked while remembering that Stridor is almost always a respiratory emergency. It may even be a life-threatening condition. So these questions need to be asked in a focused, prompt manner, remembering at all times that we may well be in a race against time. Now let's talk about the physical examination, which is very important to understand the cause of stridor. Stridor is almost always a sign of a respiratory emergency. So while performing physical examination, we need to observe if the accessory muscles of respiration are being utilized or not. This can be identified if we notice a recession in the area of the suprasternal notch or the sternum or the intercostal spaces or the epigastrium during inspiratory efforts. As previously stated, understanding whether the stridor is inspiratory, expiratory or biphasic helps us in getting clues regarding identifying the possible anatomical location of the pathology causing stridor. Associated respiratory sounds also helps us understand the possible cause of stridor. For instance, if there is a snoring sound or stertor, maybe the cause is in the nasopharynx. If there is a gurgling sound or there is muffled voice, maybe the cause is in the pharynx. If there is hoarse voice or abnormal cry, maybe the cause is in the larynx, although some exceptions exist. If there is an expiratory wheeze associated with stridor, maybe the cause is in the bronchus. If there is any associated fever, the stridor may be due to an infective condition like epiglottitis or laryngotracheobronchitis. Does the stridor disappear when the patient is in prone position? If this happens, the cause may be laryngomalacia or micrognathia or macroglossia or even compression of the innominate artery. While stridor can be heard without a stethoscope, sequential auscultation using a stethoscope by placing the stethoscope over the nose, over the open mouth, over the neck and the chest can help us to localize the site of origin of stridor. Examination of nose, tongue, jaw, pharynx and larynx can help us in identifying any local cause that may be responsible for the stridor. Indirect laryngoscopy is usually performed in cooperative adults, while in children or when nasal examination is also required, we can go for flexible fiber optic nasolaryngoscopy. It is important to remember that indirect laryngoscopy or endoscopy of the nose or even flexible fiber optic nasolaryngoscopy are not investigations. These form an integral part of physical examination, which helps us understand the possible cause of stridor. Now let us talk about the investigations that may be required in confirming the cause of the stridor. Now let's talk about the investigations that may be required to identify the cause of stridor. One of the most common causes of stridor is inhalation of foreign body. This foreign body can be identified by requesting soft tissue X-ray of the neck in the lateral view and the PA view, or X-ray of chest in the lateral view and the PA view. If the foreign body is radiolucent, then we can go for chest X-ray in expiratory phase or inspiratory phase, or even fluoroscopy. We can even request contrast enhanced CT scan if we are suspecting a mediastinal mass which may be compressing the airway and producing stridor, or even some congenital vascular anomalies may be compressing the airway and producing stridor. This can be detected in contrast enhanced CT scan. These congenital vascular anomalies can be things like double aortic arch or abnormal innominate artery, and these require surgical management. Before we go for surgical management of these vascular anomalies, we may also need to order an angiography. Now, esophagogram with contrast can also be requested if we are suspecting tracheobronchial fistula or esophageal atresia or some other esophageal conditions. These are rare causes. Now, if we have not found any cause, or if we have found a cause in the bronchus, perhaps we can go for direct laryngoscopy. This is also known as microlaryngoscopy with bronchoscopy. This is typically performed with the help of an expert anesthesiologist, and we also have to have all the emergency resuscitative measures ready. This is performed in the operation theatre, of course. And the mode of anesthesia is usually by the insufflation technique or inhalation anesthesia without an endotracheal tube. So first bronchoscopy is performed to look at any possible cause of stridor lying inferior to the subglottis. We inspect the bronchus. If there is any foreign body, we remove it. If there is any crust, we remove it. If there is any thick secretion, we remove it and we send it for microbiological analysis. If no bronchial cause is found out, if no bronchial cause is identified after bronchoscopy, we can go for microlaryngoscopy, which is basically examination of the larynx under magnification. This magnification is typically produced with the help of an operating microscope, but sometimes endoscope can also be used. So the main purpose of all these investigations is to find the cause. If we find a definitive cause, we have to start treating it. So let's now discuss the possible causes, and with that we will end this video on the approach to stridor. The causes of stridor can be congenital or acquired. Congenital causes or causes since birth of stridor can be laryngomalacia, laryngeal web, subglottic stenosis, hemangioma, vocal cord paralysis, and tongue and jaw abnormalities. Acquired causes of stridor can be subdivided into febrile causes and afebrile causes. Afebrile acquired causes may be neoplasia, injury, foreign body, laryngeal edema, and adenotonsillar hypertrophy, especially of the chronic nature. Febrile acquired causes of stridor may be acute epiglottitis, acute laryngotracheobronchitis, acute laryngitis, diphtheria, retropharyngeal abscess, peritonsillar abscess, and infectious mononucleosis. Now, based on the anatomical location, stridor can be also discussed as nasal causes of stridor, such as guanal atresia, or a tongue cause of stridor, such as macroglossia, or a mandibular cause of stridor, such as micrognathia seen in Pierre-Robin syndrome. We can even talk about pharyngeal causes such as retropharyngeal abscess. There are so many causes. I cannot come up with an exhaustive list without getting exhausted myself. There are laryngeal causes such as inflammations of the larynx, infections of the larynx, neoplasia of the larynx, trauma to the larynx, paralysis of vocal cords. There may be tracheal causes like tumor in the trachea or atresia, congenital causes, inflammation of the trachea. So many causes are possible. But we have to remember that the cause may be lying outside the airway as well, such as a foreign body in the esophagus may produce stridor in rare instances. An esophageal mass may compress the trachea and produce stridor. A mediastinal mass may compress trachea or the airway and produce stridor. There may be a vascular anomaly like double aortic arch or a vascular ring compressing on the airway and producing stridor. The key thing is we need to know how to approach, especially in MBBS ENT exams, we need to know the right approach to a patient with stridor. We need to know how to ask the right questions, which questions to ask, which examinations to perform, which investigations to order, and then the objective is to find out the cause. Once we find out the cause, we have to treat the cause. So I hope you like this video on an approach to a patient with stridor. If you noticed any mistakes, then please don't hesitate to point it out, because I love to learn from you. If you want to add to this answer, if you want to point out some things that you want to talk about, then please feel free to share it in the comment section. Thank you for watching this video. Take care, bye bye, and please don't forget to be awesome.